Good morning, my colleague. This is our ninth session in mixed Viva cases. Today, before we start, uh, we hope all the best for our colleagues who are preparing for tomorrow short and reporting exam. My advice for all of them, you did your best till now. Stay calm. Don't study too much today because tomorrow need an alert, quiet, and a comfortable body. Concentrate in your exam for tomorrow. My advice, what is in your mind is the most and the best answer that you can make tomorrow. Don't hesitate. Don't hesitate. Hesitation is the biggest enemy in tomorrow and after tomorrow. It is better for you to be trusted in yourself, write in your what is in your mind before you comment or write in anything. Take your time, see all the exam from slice one to the end of the slice. Even in long reporting, many tricks in the film age. The same advices I'm telling now to the potential candidate of today. Let's simulate, consider today as an exam. The same, don't hesitate. Look at the exam from the end to the bottom. Don't skip any slice. And then my advice is in Viva, don't tell too much unrelated information. Be specific and be clear and concise. Let's start with our candidate number one. This is a 15-year-old female patient with ankle pain.
Yes.
15-year-old.
Good morning. Good morning, doctor.
Good morning. 15-year-old female patient with ankle.
I'm trying to scrolling. It is not scrolling now.
Use the arrows. Use the arrows. Can you?
Slightly
Can you?
more sluggish.
Okay. I will scroll for you.
This ankle MRI started by T1 weighted image.
No, it started.
In a patient which is 15 years old, complaining of chronic ankle pain.
Okay. What is the name of this sequence?
This is T1 weighted.
Okay. Which T1?
Exact. Coronal. Sorry.
Yes.
Coronal.
But this is which type of sequence?
Fat set.
Look at the okay, fat set.
Fat
You
set.
can say fat set sensitive, something like this. Take care, my colleagues. Most of the sequences in the MSK are proton density, either proton without fat set or with fat set. Most. Go on, doctor.
But this is T1?
No, this is proton density.
Proton density.
Yes.
Okay.
But if you told the examiner, doctor, this is fat set, okay, it is very acceptable.
No need for specify?
If you know, it is better to specify this is proton, this is stair. What is the difference between proton fat set and the stair? The stair is markedly black than the proton. Okay, more marked black. But here, see the proton. You can see something here, yeah, from the marrow. You can pick a little bit signal in the marrow. But in a stair, it is markedly black. The marrow looks like this tendon in the stair. Okay? Yeah.
Yes. I am scrolling through the images to see the abnormality. The first striking abnormality is the presence of some joint effusion.
Okay.
Second one. The Maro signal is unremarkable.
Are you sure? Look here. 1 second. Look here. Are you sure?
There is difference in the talus between the talus and the remainder of the foot marrow.
Hmm.
Some is increased signal in the marrow on the foot
Hmm.
bone.
What
It
is
is high
the name? What is the name of this bone?
calcaneal bone,
Okay.
and there is also some linear shadow in this bone,
Hmm.
maybe attributed to stress fracture with
Mm-hmm.
surrounding marrow edema.
Okay.
In my usual practice, I will correlate with the plain radiograph if available
No
and
plain
other
radiograph.
sequence.
What
I
sequence do you want?
stare images
Okay. Which plane?
in the sagittal plane.
This is the sagittal plane.
Okay. Okay. This obviously, the relation between the talus and calcaneus is normal. There is some joint effusion as attributed by increased swelling in the joint itself. And the forementioned area of the anterior talus, and the anterior process of the talus shows some linear lucency and surrounded by marrow edema. This attributed by stress fracture.
Mm-hmm. Mm-hmm. What else? Look again, doctor. Please. Look again. What happened here? Hello? 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 Doctor, can you listen me? Candidate number 1. Hello? Hello? Doctor? Okay, anyway, thank you so much, candidate number 1, my colleague. Look here, and please, when you pick up a finding, concentrate on it. There are marked edema here. What is this? Look from the beginning, scroll. This is the medial malleolus. This is talus. This is calcaneus. Go up. Some projection, bony projection from the calcaneus medially. This is sus centiculum tilli. Okay. Okay. So you should ask for other sequences in other plane. Look here. Long, elongated anterior process of the calcaneus. Elongated. Okay. And this is the navicular. There are thin chondros or some joint here, abnormality or some fusion here. Okay. And the edema here. So this is talonavicular coalition. Talonavicular coalition. First of all, the patient has chronic pain. Second, this is a very pathognomonic sign is anteater sign, anteater nose sign. Okay, the long nose of an animal called an anteater. Okay, number two, there are edema in the navicular. So in patient 15-year-old with chronic foot pain or ankle pain, number one, put in your mind coalition, either talocalcaneus or talonavicular. Okay. Number two, stress fracture, but there are specific site for stress fracture. For the calcaneus, almost in the posterior part here. for the talus in the neck. And for the rest of foot, you should, if you are concerned about satisfaction, you should look and execute here in the metatarsal shaft. Okay, my colleagues. So your eye on the specific site of your pathology. Um, thank you so much, my colleague. Next candidate.
Assalamu alaikum.
Salam. Request control, please.
Sorry, I am on my phone again.
No problem. 30-year-old male patient complaining of abdominal discomfort and pulsatile mass.
I have been presented with axial images of CT scan for an adult patient with history of abdominal discomfort and pulsatile mass. I will take a quick look of these images, and then I will come back to my finding. First of all, I noticed that there is infrarenal abdominal aortic aneurysm.
Excellent.
Without any dissectional flap. I want to see the extension of this aneurysm. I want to assess the aortic branches such as the celiac trunk, superior-mesenteric, and both main renal arteries. I can see that there is peripheral thrombus seen within this aneurysm. I want to assess if there is any evidence of impending rupture or frank rupture. Also, I noticed that there is enlargement of the right iliacus muscle. Yes, iliacus muscle in comparison. Sorry, psoas muscle. There is enlargement of the right psoas muscle in comparison with the left psoas muscle, and showed central high. It's like a necrotic center. While the left psoas muscle appears normal, and this appears extended into the iliacus muscle. So I have, which is abscess collection within the iliopsoas muscle.
Excellent.
I want to check the bone window for this patient to see if there is any, yes. Now I'm assessing the coronal images. I can see that there is extensive abscess within the previously mentioned muscles, and this could show extension into the pelvis and then into the proximal part of the right upper lower limb.
What's your differential? يعني say I advised all of you many times, don't repeat the finding when you are presented with another sequence or another plane. Don't repeat.
Yes.
You can tell the examiner, doctor, this coronal confirms the finding that I mentioned in the exam. Okay. What is your differential diagnosis?
My differential diagnosis, this could be due to infectious cause and with aortic aneurysm. These could be related, such as mycotic aortic aneurysm.
Excellent. What's your next step? Tell me about the management. Okay, excellent. What is the management?
My management, I will see if there is any pathway for drainage. I will use ultrasound guided for drainage if there is any access posteriorly. If not, I will go for CT guided drainage, and I want to do analysis and drainage for this collection, and then I will transfer this patient into the vascular team for the aortic aneurysm review.
Okay, what in your mind, in your opinion, what is the first line of management of mycotic aneurysm?
Anti-mycotic aneurysm. First, I will start with the antibiotics.
Okay.
Then there is which is called endovascular aortic repair, which is called EVAR, something like this.
Thank you, doctor, so much. This is a left psoas abscess complicated with mycotic aneurysm. See my colleagues here. See, this is after treatment. Marked reduction of the aneurysm diameter itself, and either drainage or whatever they did. I think there, see doctor, there are element of surgery here. Midline laparotomy. So I didn't accept really that you can drainage a psoas abscess either by ultrasound. It is very difficult, really. I'm not expert. See, there are scar tissue here. I'm not expert in intervention, but it is very difficult. If I am in your situation, I will transfer to the vascular team for drainage antibiotic and for repairing, if possible, of the aneurysm. Okay, but don't tell yani unlogic. First of all, you did very well, by the way. Okay, did very well, but don't insinuate yourself in يعني a difficult situation, because you were running very well in the correct pathway, and you told me, doctor, I wanted to drainage. See the source. How could you go through which pathway you can go through by ultrasound or CT to drainage this huge abscess? The size and the location, I think, is incompatible with interventional drainage. See, very large, and it is most very posterior, retroperitoneal. See, thank you, doctor, so much. And I think they need to drainage this pre-vascular collection also. See, I think also. See? Large. Thank you, doctor, so much. This is a mycotic aortic aneurysm due to large left psoas abscess. You can tell the examiner, doctor, I want to exclude TP. I will ask for chest X-ray and acid fast bacillus. This is very good. Or like you did, doctor, I want to see the bone window to exclude any associated spondylolisthesis. Very logic. Thank you, doctor, so much. Next candidate.
Hello.
Next. Hello. Could you request
Hello.
control, please?
Sir, I have requested remote control.
Thank you. 8-year-old female patient presented with long-standing hypertension and altered sensorium. Go on.
Okay, these are non-enhanced CT sections of the head axial sections, brain window.
Yes.
Scrolling. There are foci of bilateral basal ganglia calcifications. The rest of the brain, I'm looking at the ventricular system. I think the ventricular system also seems to be unremarkable. I'm looking for any evidence of ischemia or hemorrhage. Yeah, in the posterior, sorry, so it is jumping.
Stop here. Stop.
Yeah.
Look here. What happened?
Sir, my mouse was jumping.
Okay. What happened?
I was suspecting, right, in these regions. I can appreciate that there are certain regions of hypodensities involving the white matter in the bilateral posterior parietal regions.
Okay.
Right over here. These ones. These could represent foci of ischemia. However, in my routine practice, I will like to change the window to further confirm my findings for posterior reversible encephalopathy.
Excellent.
The other differentials in this case would be dural sinus thrombosis, for which I would like to see
What do you want to do?
I will, further like to see the MRI images, further imaging MRI. Okay. I don't know why my mouse is creating problem. Okay, in this T2 weighted axial sections of the brain, further confirms the findings of. Sir, can you please scroll? I think my mouse
Leave
has
the
some
mouse.
problem.
Leave the mouse.
Okay, okay. Again confirms the abnormal cigar intensity areas in the bilateral posterior parietal regions. Also, further supporting the diagnosis of posterior reversible encephalopathy syndrome or BRESS.
Excellent.
Also, I can appreciate few foci of hyperintensities in the temporal regions, more on left side. So I will inform the findings to the referring physician. Yeah, this is susceptibility weighted image. Um, it shows again bilateral foci of basal ganglia, and also there are multiple foci of hypointensities. These are blooming artifacts in the susceptibility weighted imaging. Um, so other
What's your
differentials.
diagnosis? See, doctor, you describe very well, and you stopped. What is this finding here? This is slide suggestive.
These are small
What?
microhemorrhages. Usually, small microhemorrhages, or
Yes,
they
yes.
show blooming artifacts.
What is the
Yeah,
etiology?
these.
Give me some differential according to the location.
Yeah, these could be due to small vessel ischemia, or
No,
due to renal disease, due to
no,
encephalopathy related to renal.
no. Look here. Where is the location? Where here? Where?
These are gray matter and also the white matter.
Yes,
These
yes.
are amyloid.
So,
Yeah,
what is the
these could be
etiology?
amyloid. Amyloid.
Amyloid.
These could be related to amyloid angiopathy.
Excellent. What is your differential diagnosis for this picture?
Sir, other differentials in this case would be some hemorrhagic metastasis,
Okay, what
or
else?
some AV less likely vascular malformations
What
showing
else?
small foci of hemorrhage,
What
or
else?
diffuse axonal injury. Diffuse axonal injury can
Okay,
give
what else?
appearance like this,
What else?
uh, or due to hypertension related
No,
some.
no. Where is the hypertension? Usai. The microhemorrhage. Where is the exact location of hypertensive microhemorrhage? This one
These are
in the basal ganglia.
basal ganglia. Yeah, basal
Okay,
ganglia.
but for the corticomedullary, you enumerate most of the differential plus calcified stage of neurocystic
Okay.
Doctor, could you tell me what is the cause of why in breast this edema occur? What is the underlying pathophysiology?
Sir, this could be due to a spasm of the vessels.
See, the patient has hypertension, okay, and sometimes the patient with preeclampsia or toxemia. This is all are the etiology of the breast posterior reversible encephalopathy. What is the underlying brain pathophysiology? What happened for the brain so that we get this picture, we get this vasogenic edema? Mm.
Sir, I don't have exact knowledge regarding this. However, I
Okay,
think
see,
blood
this
pressure is
hypertension or toxemia or preeclampsia affect the blood-brain barrier, correct?
okay.
Okay, destroy the blood-brain barrier, so result in vasogenic edema. Okay,
Yeah.
okay. Fine. Do you expect any restricted diffusion in diffusion weighted image or not?
Yeah, please.
Impress.
In these ADC,
Impress. This is EDC.
no,
Impress.
this is ADC.
Hmm.
Yeah, in the there is no diffusion. So I think
Why?
in this case,
Why? Because breast
because there is
cytotoxic or vasogenic edema.
yeah, there is a break of blood-brain barrier. You already said.
Thank you, doctor. You did
That's
very
why.
well. It was a case of breast and amyloid angiopathy. Here, the most striking abnormality, you can tell the examiner, doctor, there are marked white matter hypodensity. More predominant where posteriorly here. See my colleague here and here. Okay. And in correlation with the hypertension, you should tell the examiner, I highly suspected breast. The examiner immediately will ask you what is breast. Breast is posterior reversible phalopsy. Okay, my colleagues, then ask for MRI. This is MRI, very clear. This is a vasogenic edema involving mainly the posterior part, either see, occipital, parietal. Okay, my colleagues, due to damage, a little bit here, by the way, by temporal, because due to damage of the blood-brain barrier. What is your treatment? ICU admission. This patient should be admitted. They should regulate the heart, the blood pressure, give some anti-edematous to the brain, and so on. Here, what happened? This is SWI, the most sensitive sequence for hemorrhage. Okay, my colleagues, what happened here? Multiple innumerable variable size foci of susceptibility, blooming or blooming artifact, where the location is very critical between the cortex and the white matter, corticomedullary. And this location is specific for amyloid angiopathy, number one, especially the patient is old age. And enumerate other causes. But if the examiner asks you, because this is an obvious case, this is amyloid. Other causes like melanoma, metastatic hemorrhagic metastasis, and calcified neurocystic. For the hypertension, micro bleeding occur in the basal ganglia. Chronic hypertension, like here, like here, like here. But this in the globus pallidus, this is age-related calcification. Thank you, doctor, so much. You did very well. Next candidate.
Thank you, sir.
Welcome.
Hello. Good morning, doctor.
Good morning. 50-year-old request control, please.
Okay.
50-year-old female patient presented with fever, productive cough.
Okay. I'm presented with a frontal chest radiograph for a 50 years old female patient presented with productive cough. I can see that there is bilateral obliteration of both costophrenic angles, which indicates small volume pleural effusion. I would like to check the right hilar is slightly bulky, but I can see the hilar points, so I'm not concerned about it, and the lungs appear normal. There's some basal reticulations.
Okay.
Reticulonodular, actually, some nodules. It's bilateral basal, reticulonodular. The heart is normal in size. The bone looks fine. I can't appreciate any abnormality. Both breast shadows are seen, and soft tissue appear normal. So I'm suspecting that this might be interstitial lung disease affecting both lower lobes. So I would like to refer the patient to the respiratory team and ask for further assessment by high resolution CT.
Okay. This is CT.
Okay. This is a high resolution CT. I can see that the patient is intubated and there is multiple scattered consolidative patches seen central and periphery in both lungs, in affecting all the lobes, with lower lobe is more affected, lower lobes. It is more peripherally consolidative patch with areas of ground glossing, yeah, and there's interstitial thickening. So I'm suspecting that this might be cryptogenic organizing pneumonia.
Okay, what else?
And in my routine practice, I would like to check the mediastinal window to check if there's any associated lymph nodes. And yeah, this is maybe cryptogenic organizing pneumonia. I would like to ask about the immune state of the patient. If she is immunocompromised, this may be
No, she is immunocompetent, but the patient has fever.
has fever. Okay, this may be bronchopneumonia.
Okay.
Um,
What else?
maybe
Yes, there
septic.
are some findings. See. Okay. Yes, look here.
Okay, this is CT brain for the same
Of the same
patient.
patient, yes.
Okay, this is CT brain with contrast. Okay, this is not brain. This is neck. Okay, I can't. No. No. Okay, this is neck vessels. I would like to check the neck vessels. So there's hypodensity seen here in the. This
Excellent.
This is the internal jugular vein. So this is thrombosis in the left. It's in the left internal jugular.
Okay, so conclude.
So this is maybe this is septic emboli with the lesions in the lung.
Okay, so finally.
So this is a patient presented with thrombosis of the left internal jugular vein with multiple septic emboli seen in both lungs.
Yes.
I would
so
like
finally conclude.
Yeah, it has a name, but I can't remember the name now.
Okay, see, at least tell me this is a case of bronchopneumonia,
Yeah.
complicated by
Complicated by thrombosis of the left jugular vein.
You are thinking about the specific name.
Yeah,
Okay?
Lemire disease.
No, I didn't think so. Why? Because Lemire should associated with local inflammation.
Okay, the inflammation in the jugular first. Okay.
So I don't know if there are something here. The image is not clear. It may be
Yeah,
there.
I think
there are some abscesses here. So if
abscesses
there
here,
are, this is abscesses are. So in this case, we can say that this is a Lemire disease.
Lemire
See my
disease.
colleagues, see here, but really it is collection, no problem. So thank you, doctor, so much. You did very well. This is a case of bilateral severe bronchopneumonia. From the beginning, the doctor picked up that changes in the X-ray, and this is the key. See, despite the CT is show multiple bilateral consolidation, here the X-ray looks like a mild inflammatory changes. Number two, look here, look here. There are number one bilateral posterior, mainly on the left side, posterior perivertebral abscesses. Okay, complicated by thrombosis in the jugular. Okay, my colleague. Unfortunately, the Radiopedia didn't mention anything about this. Okay, so this is a case of bronchopneumonia hidden by abscesses in the cervical spine and Lumiere syndrome. Thank you, doctor, so much.
Thank
Very
you,
well.
doctor. Thank
Next
you.
candidate.
Assalamu alaikum.
Candidate.
Next, candidate 5.
Request control, please.
Okay. I have
That is
requested.
why That is why my colleagues, we should يعني, didn't 100% depend on the diagnosis of Radiopedia or other site. We should also revise what they write. Sometimes they didn't mention many important findings. Okay, doctor, this patient, 8-year-old male patient, presented with abdominal pain and fever, tachycardia. Go on.
Okay. Telling my mouse is. I'm trying to scroll.
Use the arrow.
Okay.
No, the arrow. See? Yeah, okay. Leave the... Okay.
Yeah, I am scrolling from top to from bottom to top before commenting.
Mhm.
In the basal lung fields, there is a consolidation in the left lower lobe. I can see ascites, some fluid adjacent to the liver and spleen.
Mhm.
Pancreas is unremarkable. Gallbladder appears normal. I would see the bowel.
Mhm.
This is a plain CT scan. There is calcification of the abdominal aorta.
What else?
Yes. There appears to be some surgical clips in the pelvic region.
Excellent.
There is fat stranding also noted in the pelvic region. There appears to be a wall thickening of the sigmoid colon. With surgical clips noted in the rectum.
Okay, what else?
I am tracing the bowel to see. There is also evidence of pneumobilia.
Okay, but concentrate in the pelvis.
Okay. In my routine practice, I would also like to see the lung window for free intraperitoneal air.
No, this is more than enough.
Okay.
Concentrate in the pelvis.
The urinary bladder is underfilled. However, this is unremarkable. I cannot see any communication.
Stop here. Stop.
Okay.
Stop here. What happened here? What is this? What is this?
Surgical clips and
Okay. First thing coming in your mind in patient with fever and has surgery here, and it looks like recent
yes,
surgery.
there is actually extensive fats trending.
No, wait.
So yes, sorry.
See, this patient looks like recent surgery. Okay,
Okay.
recent surgery. And first thing come in your mind here, is this anastomosis or not?
Yes, it is.
Okay, so what you are concerned about?
About the leakage.
Okay, did you find any clue of leakage?
Um,
Hmm. Did you find anything?
There is fluid fluid is there in the upper abdomen.
Only fluid? What is this?
High density fluid,
What is this?
free air,
Yes, air fluid level.
air
Okay,
fluid level. Yes. Okay.
okay, correct,
Yes. Okay. Yes.
correct. Second, look at just beside the anastomosis. What is this?
There is free air.
Okay, so give me your diagnosis, please.
So this is a case of previous surgery in the region of in the rectosigmoid region with anastomosis, and there is a potential anastomosis and leakage with collection and air fluid level in the abdomen. Also free intraperitoneal air as well as pneumobilia.
Okay, what is your next step?
Next step, I would like to see it in the contrast enhanced CT scan, and I will immediately inform the referring clinician about the finding as this patient needs urgent intervention.
Thank you, doctor, so much. My colleague take a home message today. This is a patient who have 80 years old, has fever, and then you are presented with axial. Okay, what is this? Also, we didn't comment in this. Anyway, first of all, you take an idea about the film. Look, down. There are a surgery here, and you go down. There are evidence this surgery may be not an old surgery. These are post-operative changes.
Yeah.
So look inside the abdomen. Look inside, especially in the non-contrast, many surgical clips. Okay? You should ask yourself, what type of surgery? This is bowel surgery. Oh, doctor, I should be worried about leakage. Number one, in correlation with the patient history and the surgery, number one. Number two, infection. Is there are any collection here? No, just an air pocket here beside. And what else? You did very well, doctor, by the way, when you asked for a lung window, but actually I didn't have lung window. But if you didn't have lung window, go up. See here, what happened here? See,
Yes.
this is ascites, okay?
Yes.
This is air fluid level, okay? So
Right.
this is hydropneumoperitoneum. One colleague may ask me, doctor, I'm not sure. This is maybe the transverse column. Okay, go up. What do you think the transverse column can be in this situation? And what about this fluid? Your concern is accepted. This concern is accepted, but we should exclude from the axial as possible, as much as possible. If the examiner tell you, doctor, we didn't have any lung wound, we didn't have any other plane, we should squeeze the case. See here, my colleagues, pockets of air, pockets of air. Okay. I think Dr. Ismail told us one advice before. when you are coming from the chest to the abdomen, first pick up any pneumoperitoneum. See, I'm coming from the chest down. This is the diaphragm, by the way. Okay, down. Oh, what is this? What is large amount? At least if you told the examiner, leave the mouse, leave. If you told the examiner, doctor, this is large collection of air in correlation with the patient anastomosis, surgery, and the fever, I'm so worried about pneumoperitoneum. I should change to the lung wound. At least you put yourself in the correct pathway, or you save yourself. Okay, my colleague. Somebody may ask me, doctor, it may be Chilaiditi syndrome. Okay, the doctor, leave the mouse, please. Leave the mouse. Could you think where is the haustration here? No any haustration. Okay, my colleague. No any haustration. Where is the colon? This is, see, this is the colon. This one. Okay. Second, we should comment on this lesion in the post contrast. There are a right hepatic focal lesion. It may be metastatic. See, multiple. 1, 2, 3. 1, 2, 3. So it was a cancer colon, status post colectomy, complicated by leakage, and there are, see the metastasis, multiple hepatic metastasis. See, my colleagues. One colleague may ask, doctor, it may be an abscess. The patient has fever. Okay. I will not argue too much, but at least mention there are multiple scatter variable size hepatic lesions. Start with the arterial and then venous and delayed, and compare with the previous preoperative images. I think it is more likely to be myths rather than abscesses. Thank you, doctor, so much. Take care, my colleagues. Many cases in Viva is complex. Thank you, doctor, so much. Next candidate.
Assalamualaikum, sir.
Wassalam. And again and again, all this finding not mentioned in the report of Radiopedia. They didn't talk about this large pneumoperitoneum or the hepatic metastasis. So we must revise any site we are studying from. We must revise by ourselves the images. Doctor, request control, please. 5-year-old female patient presented with loss of vision in both eye following fever.
Okay, sir. Okay, I'm presented with an MRI of the pediatric age group patient who has lost vision in the eyes. First, I'm going to scroll from top to bottom or bottom to top. And now I am going to look. These are T2 weighted images, axial sections, in which I can see that there are multiple areas of hyper intense signal return noted from predominantly from white matter. They are reaching up to subcortical white matter also, predominantly affecting the right parietal lobe and top parietal location. Now there is some area of cystic leukomalacia is also noted, but I will confirm it in other sequences as well. I would like to know about the history of fever, because in patients of pediatric age group, ADEM can one of the causes of sudden visual loss, but I cannot see any significant involvement of the gray matter. Sir, can you please show me other sequences such as flare or diffusion, so I can see other lesions if there are? So can I see flare images?
Yes, sure.
Okay. Okay, these are the FLAIR images of the same patient. There is mild subependymal irregularity. Again, the same lesions are redemonstrated in the white matter of the parietal region bilateral, more on the left side, more on the right side. Reaching up to subcortical white matter, some hyper intensities are also noted in peri-occipital region. There is evidence of a small hyperintense focus noted at the level of the foramen of Monro also. Some hyperintense signals are also noted in the perifrontal region on the left side. So can I see diffusion weighted images or post contrast?
This is diffusion.
Okay. On the
What you are,
diffusion weighted
doctor?
images.
Look, see,
Yes.
you
Yes, sir.
you just have seen two sequences and you didn't give me any differential.
Sir, I was thinking about Adam, but
Okay.
there was
Okay, one second. Did you
okay.
tell me? Did you tell me
Yes,
this concern? Hmm?
sir. I told you that I was thinking about Adam, but there was no significant involvement of the gray matter, so that's why I
Okay,
refrained
great.
from explaining it further.
Okay, great.
Okay, sir. So there are some patchy sort of restriction in the cortical area also, but I will confirm it on ADC if there is if it is matching with it or not.
I think no
But
EDC.
it is okay,
This
sir.
EDC. Okay, EDC.
Yeah, there is no significant restriction, but these lesions are also not showing any significant restriction.
So what's your differential diagnosis?
Sir, in pediatric age group, these can be demyelination.
Yes. What type of
Because
demyelination? What type?
infective, maybe. I would confirm it on post-contrast if it shows any post-contrast enhancement. And
Doctor, did you remember the advice that I gave you yesterday?
What, sir?
Did you remember my advice you yesterday?
Sir, sagittal
No.
images.
No. I gave you specific advice yesterday. What is your first differential diagnosis, doctor?
Adam, my first
This is the
differential
correct
diagnosis.
diagnosis. This is the correct diagnosis. Yesterday I advised you have the good knowledge, trust in your first concern. Okay?
Okay, sir. Okay, sir.
Okay? You are right. I have a question. What is the
Okay, sir.
difference between Adam? What is Adam? Would you tell me?
Acute demyelinating encephalomalacia.
No.
Sir, I'm Adam
What is
means
Adam? Acute disseminated encephalomalacia.
disseminated. Okay,
What is the difference
disseminated.
between Adam and MS? Pathologically or
MS,
radiologically?
yes, sir. MS usually involves white matter only, and it is present at the clososeptal margin, and it is usually present in adult age group patient. And in Adam, it is mostly involving white matter, but some gray matter areas can also be involved, and it is usually associated with acute viral infections. So I would like to
Or
ask
vaccine
about history
or
vaccine.
post-vaccination. Okay, but
Yes, sir.
pathologically, what is the difference between them? Between both of them pathologically?
Pathological, so I think there is some difference between monoclonal antibodies, which are seen in MS, and
See, you can find
MS is okay, sir.
you can find MS in multiple stage, active, inactive, subacute,
Yes, sir.
chronic.
Yes, sir.
So
Dissemination, time and place.
yeah, MS. So what is the name of this process? Polyphasic or multiphasic?
Okay, sir.
Polyphasic or monophasic? Polyphasic. So the
Yes,
MS is polyphasic. What
polyphasic.
what does it mean? It means you can at the same patient, at the same MRI time, you can find one MS active or acute plaque, another one subacute, another one chronic. But Adam is monophasic.
Monophasic.
Either all the lesions here in the same stage, either acute, so all of
Or
them are
chronic.
acute, all of them are chronic. So this is a very important point. Thank you, doctor, so much. My colleague,
Thank you, sir.
young, thank you, doctor. Young
Thank you, sir.
child has fever, then has abnormality in the brain, whatever the abnormality, visual loss, sensory loss, whatever. So put Adam at the top of your differential diagnosis. What happened here? Demyelinating or signal abnormality areas. Okay, when we saw the diffusion, no any restricted diffusion at all. Okay, so this is Adam. And what happened here? Doctor, you didn't comment in the optic nerve. The main complaint of the patient is visual abnormality.
Neuromyelitis optica.
Yeah, neuromyelitis optica, I think this term is more related to MS. But at least you can say, doctor, this is optic neuritis. See, my colleagues,
Neuritis.
don't insinuate yourself in debate with the examiner. Which more easier for you to tell, neuromyelitis optica or optic neuritis? Optic neuritis.
Optic neuritis
Whatever,
in this case.
okay, whatever the cause. Look here, my colleague. Look here. There are, I think, this one. Look, concentrate, please, my colleague, at the optic nerves. See?
Yes, sir.
Especially at the chiasm. The chiasm is totally abnormal.
Yes, sir.
Okay, and I think there are this one more obvious. What is the best sequence to evaluate the optic nerve, doctor?
Sir, optic nerve, I think a flare, coronal flare.
See, my
Yes,
colleague,
sir.
high signal. Doctor, I'm confused. How can I differentiate? Look at the nearby brain tissue. This is
Yes.
obviously signal abnormality. This is the optic nerve is more bright. See, my colleague, optic nerve, optic chiasm is more bright. Follow the optic nerve course. Follow. See, here a little bit higher. The best sequence for detecting optic abnormality or even orbital abnormality is stare, because here many fats, the orbital fats confusing us. So the best sequence is stare. Thank you so much, doctor. This is Adam, complicated by optic neuritis. Bilateral, more obvious at the right side. Next candidate.
Sir, can you please scroll for me? I'm unable to scroll. I'm through my phone.
Okay. 45-year-old female patient presented with proptosis and decreased visual acuity.
Okay, so I'm provided with axial T2 images of a
No,
patient.
take this.
Sir, I'm provided with the flare images of the patient who presented with proptosis. First, I want to look at the optic nerves. Sir, I could appreciate that the orbital muscles appear slightly bulky, predominantly on the left, especially the medial rectus appears swollen, and there is crowd at the level of they're compressing the optic nerve, and it appears narrowed at the level of optic canal. I also appreciate that there is mild stranding of the fat noted in bilateral muscles. Sir, I'm
Okay.
thinking of thyroid ophthalmopathy and pseudotumor, and I would like a T2 sequence first, as I know that the pseudotumor is low on T2. I'm provided with the T1. On the T1, it is the muscle is iso-intense but significantly swollen and bulky.
See, this is post-contrast.
Yeah. Sir, on the post-contrast, I could see enhancement of the muscle bellies with the ten. So, can you please comment the level of optic nerves again, muscles again? Sir, I think the tendons they might be spared. Not sure. I think they are involved.
Correct, correct, you are correct. So what is in top of your differential list?
The top is pseudotumor, as the tendons are involved when there is
Excellent.
inflammation of the orbital fat, and
What else?
the
What else here?
uh,
Look here. What happened?
uh, sir, on this sequence,
Yes. What happened here?
uh,
What happened?
so yeah, there is an pachymeningeal enhancement noted.
Okay. So what's your first differential diagnosis?
Uh, Sir, maybe optic neuritis.
No,
No,
doctor, you were in the
no,
correct pathway.
or
Pseudotumor.
cellulitis maybe.
See,
Okay,
doctor. So this is confirm the diagnosis of pseudotumor
okay, okay,
because
okay, okay.
orbital thyroid orbitopathy didn't cause meningeal thickening or enhancement.
Yeah, yeah, yeah. Okay.
Correct?
Sorry. Yes, sir.
So
Orbital
mm,
tumor.
what's your final diagnosis?
Sir, orbital pseudotumor.
Okay. What is the relation of orbital pseudotumor with this meningeal enhancement? What?
Uh,
mm,
Sir, I'm
Give
not
me
sure.
a
I
hint.
think it's
Yes. It is a
um.
different entity or they associated with each other?
Sir, I think it's associated.
Yes. Thank you, doctor, so much. See my colleagues here. See, you can't detect, differentiate the muscles at all. There are an infiltrative, ill-defined process in both orbital. Okay, this is in the site of inflammation, pseudotumor. But in thyroid orbitopathy, if you at least bring the coronal, you can detect the muscle by muscle. Here, everything is mixed and diffused, and also here. And the most striking sign here is signal abnormality and the swallowing, intraorbital signal abnormality, swallowing, and يعني mixing or conglomeration of the component. This is in the site of inflammation rather than thyroid orbitopathy. And then after I show the doctor this post-contrast, what happened here? There are meningeal thickening and enhancement. This is not in the site of thyroid orbitopathy. Okay, this is pseudotumor. Pseudotumor is associated with meningeal affection or meningitis. Also, you should tell the examiner, doctor, I wanted to exclude IgG4, IgG4 because it is very common to cause orbital pseudotumor and meningitis, and the other associated symptoms and signs of IgG4 like thyroid inflammation, thyroiditis, and cholangitis, autoimmune pancreatitis. Okay, here the team did this investigation, by the way. See, I think they did chest and the abdomen, but both of them were normal. Look at the pancreas. This pancreas is a little bit confusing, but really there are some digitation and there are no halo sign to be 100% sure if this autoimmune pancreatitis or not, because it is a little bit bulky. Why? How old the patient? 45. But the digitation, there are some digitation and no halo sign. It was a case of orbital pseudotumor. Thank you, doctor. Next candidate.
Assalamu alaikum, sir.
Ask control, please.
Sir, it is not showing. There is no option coming for requesting control today.
Okay, I will for you. 50-year-old male patient, right lean pain and fever.
These are plain CT abdomen image in a 50 years old male patient. These are contrast enhanced image in the
Okay.
corticomedullary phase, portal venous phase. I can appreciate that there is a differential contrast enhancement in both kidneys. There is some right basal atelectasis, some pleural effusion. The right kidney is showing patchy areas of
One second.
hypotension.
One second. Suppose that the examiner is scrolling for you for any technical abnormality. Okay? When you pick up the pathology, the cache is here. Okay? Ask the examiner, please, doctor, come back. Okay? He will, by the way, he will tell you, I will scroll for you and stop me of the slice of internet. Okay, doctor, please stop here and start to describe. If you want him to scroll up little bit, again, guide him. Okay, my doctor.
Okay.
Okay. Right.
Okay, this is the site of pathology. In my routine practice, I would see the whole series of stack of the images. But as I found the pathology here, I will comment on it first. So there's a hypodensity which is wedge shaped. It is involving a very clear plane. There is some fat standing adjacent to it. I will try to look for, I'm thinking in the lines of any infarction. And so I will try to look for any thrombus or other possibilities coming to my mind are some abscess or glomerulonephritic changes. I will try to look for right renal artery, any filling defect in it. There is some swelling of the renal vein, the right renal vein.
Are
The
you sure?
artery.
Are you sure? 1 second. Where is the renal vein?
Sir, it is no. Sorry, I think I shouldn't comment. It is the arterial phase.
Yes, in this phase.
In
What's
this
your
phase,
first diagnosis?
sir, in this phase, I'm thinking of either infarction or some transitional cell carcinoma. These two are possibilities. I would like to see any
Doctor,
other.
1 second. Did you remember the history? Again, I will show you the history.
Right loin pain and fever. Okay. Sorry.
This is
I
very
forgot that.
critical. The examiner will not guide you like this. Okay? The history, if the examiner tell you a history, he will demarcate you because he gave you a very nice clue. You should use it. Okay, my friend?
Okay.
Look again, doctor, to both kidneys. This is the pathology is not in one kidney.
Okay. So there are hypodensities in the right kidney, as well as some small hypodense areas in the posterior part of the posterior part of the cortex of the left kidney as well. So if you can scroll, and the anterior part as well.
So correlate with the history. What is
So
the matter?
Can be multiple abscesses or
Okay.
multiple patches of glomerulonephritis. Sir, can I see the coronal plane as well to confirm?
No, this is very conclusive.
Very conclusive. There is the overlying cortex is showing no scarring. So I don't think this is a chronic process. It looks like acute multiple.
Doctor, what happened here? What happened in the right?
In the right side, there is perirenal fat is showing inflammatory changes.
Okay.
And multiple areas of hypodensities and reduced enhancement.
So give me your final diagnosis.
So there are bilateral renal abscesses with pre and pararenal inflammatory changes and collections in the on the right side, and focal
Okay,
areas of small
what is the name
abscesses
of this sign? See, look at the kidney. What is the name of this sign?
this sign. Sir, I don't remember the name.
Okay, see,
I don't remember.
here. What is the name of this sign?
This is striated nephrogram.
Excellent. So give me a final diagnosis.
So, sir, there is a striated nephrogram on the right
Yes,
side, which is due to, in this particular case, is due to renal infection with the development of
yes. What is
abscess,
the name of renal infection?
acute pyelonephritis,
Excellent. Excellent. Thank you, doctor, so
bilateral.
much. Thank you so much. No, see, my colleagues, what happened here? The patient has a fever from the beginning. Don't forget the history. Number two, the kidney show multiple alternative, see, bilaterally hypodensity, but this is not hypodensity, this is hypoenhancement because we are in a contrast phase. This, look deeply in this wedge shape or triangular hypodensity. No peripheral or peripheral enhancement here, okay, which is a characteristic for renal infarction. In renal infarction, you find here a capsular enhancement, marginal enhancement. And the second point, doctor did very well. She exclude any venous or arterial occlusion. Okay, this is very good. So we are talking about something else rather than infarction. Look at the very renal fat. There are marked stranding. Okay, so this is a case of pyelonephritis. What is the name of this sign? Striated nephrogram. Why the nephrogram is striated? Why there are no excretion here or here or here? Because the glomeruli are obstructed by the inflammatory cells itself. So there are no excretion by these regions. Thank you, doctor, so much. Next
So,
candidate.
sir, it was a acute glomerulonephritis complicated by focal areas of infarctions.
No. This is pyelonephritis. Normal, regular pyelonephritis. Okay.
Okay.
In glomerulonephritis, يعني I think glomerulonephritis is an autoimmune disease. I think you can't find all this extensive very renal fat smudging. Okay, my colleague. And the
Okay.
second,
Thank you,
see,
sir.
doctor, here I will show something to be 100% persuaded. What is this? See here, what happened here? Look at the renal pelvis. It is very thick, I think here. Look at that, see? The renal pelvis and the upper ureter, thick, enhanced, see? This
This
is
is
not
pyelonephritis.
acceptable in glomerulonephritis, okay? In CT or in radiology, we are puzzling. We are putting one puzzle beside another puzzle to give the final logic diagnosis. Thank you, doctor, so much. Next candidate.
Hello, doctor.
Hello, request control, please.
Okay, requested.
One second.
Okay.
You didn't need any history?
Yeah, can I get the history, please? Okay,
40-year-old
abdominal.
female patient with abdominal vein. Go on.
Gastric bypass. Okay. Okay. So this is abdominal CT, axial cuts, portovenous phase. Going through the whole series. Okay. Okay. Okay, so so this is there is mild amount, a moderate amount of pelvic ascites, and dilated small bowel loops
Doctor,
filled with fluid.
could you raise your voice?
Okay, there is multiple dilated
This is
small
very
bowel.
important. It is very important. As you told you yesterday, the examiner is building a complete impression about you, even from the body language. He look you at the camera, from your voice tone. Your voice tone give him an idea about you. Very
Okay.
important.
Okay.
Okay.
So there is dilated small bowel loops
Okay.
filled with fluid, and this is the transition
Excellent.
point. From the valvular events pattern, these are jejunal loops.
Okay. Excellent.
So I'm going to at the transition point. I can't see any. I'm sorry. I can see. Yeah,
Stop
I
here.
think there
Stop
is
here.
a
No. Go back.
fire.
Go back. Go back.
Okay. Okay.
Give them one. What happened?
Okay.
What
There is
happened?
a swirl sign, I think, but I want to confirm it. And
But could
this
you didn't tell me about something
yeah,
here?
this is the the suture,
Okay,
surgical sutures.
Okay, so this is a case of
Post-operative.
Okay, 1 second.
Yeah.
Look at the skin. Could you detect any scar?
No.
It is very important and very good skill during your searching in the CT. Could you detect any scar?
No.
So this is an open surgical procedure or a
laparoscopic. Okay,
laparoscopic.
and
Patient has
yeah.
pain and there are dilatation. What is in your mind before detecting any transitional point? What is coming in your mind now?
Post-operative complication.
Yes. What is the most common complication of laparoscopic surgery?
Internal hernia.
Excellent. Excellent. See, before you detecting the transitional point, you answer. Why from the scenario of the case? Where is the transitional point?
That one that I pointed, this one. Okay, and this is close to the surgical clips.
Yes.
With the swirl sign around.
How many transitional points, doctor?
I would
you
like
told
to
me
check
you are
for
searching
another one.
Yeah, you are searching for internal hernia.
Yes,
So,
because if it's an internal hernia, it will be a closed loop obstruction.
Okay.
So I would like to check first axial cuts and sorry, it's doctor, are you scrolling with me?
No.
Okay, so because it's not okay. So I'm trying to look at the proximal end.
No.
So it seems to be dilated and up to the proximal
Look,
jejunal loops.
In
Okay.
closed loop or internal hernia, almost both.
Coronal view.
No. Both point of transition are beside each other.
And
Why? Because they
yes,
enter from one defect. See here?
Yes.
Yeah. No. See here?
Okay.
This?
Okay.
What happened? This is one. See?
Okay.
Beside each other. Okay?
Okay.
Look here.
Okay, so this
See?
looks like
one and
C-shaped.
This one. Okay. Where is the exact location of this internal hernia?
Might be left paraduodenal, but it looks a bit lower.
Okay. No problem. The exact location this side.
Transmittent.
Okay, no problem. But at
okay.
least you pick up the findings. Okay. Anything do you want to
So,
tell me?
yeah, so I would like to check. I think there is a diminished contrast mural enhancement of the wall.
Okay. Is this ischemic towel or just hypo-enhancing or normal? You have three choices. You can scroll, by the way. Scroll.
Okay, I'm trying. In case of closed bowel loop obstruction, this might be ischemic because of the
Yes, yes. In this
compression
case,
of the venous
I'm
drainage.
talking about this case. What
Yes,
happened?
this is, yeah, it looks most probably to be ischemic.
No. Look again.
Um,
Look again and compare. Look again. Stop here. Stop here.
okay.
It is hypo-enhancing. Because see, you can detect some mural enhancement. But
Maybe
not
edema first.
okay, and the edema, but not like this. See, not like this. This is normal, by the way. Here is less than here, but still we can detect some enhancement. Okay. What else you wanted to exclude in this case? Very important. This is a status post-operative, so you should exclude something important.
So I'd like to check for pneumoperitoneum and vascular structures.
Excellent. Why you wanted to rule pneumoperitoneum?
Because of any bowel perforation or leakage.
No, leakage. Because this is
there is already a fluid.
bypass.
Yeah.
This is a bypass stage. Okay. Okay. Thank you, doctor, so much. See my colleagues here. There are many skills that we should get during this live session. Number one, from the history, you can have some concerns about the case. Okay. First of all, the patient has from the case abdominal pain. The examiner will not tell you the patient has a history of surgery or bypass, and I didn't tell her this history of surgery. Number two, when you are examining, you should your eye also in the skin. Is there are any surgical incision or not? No, any surgical incision, and there are multiple steps inside. There are sutures inside. So this operation is done laparoscopic and with dilated bowels. So this should be an internal hernia. My job now to find the transition point or point of transition. See, this is dilated. Follow it, then change of caliber here. This is one of see here, one of the transition point. Okay, look here also. Follow it. Follow. This loop, follow this loop. Down. This loop. Down. There are a transition point here. So this is the site of herniation. Okay, my colleagues, and we should comment on the mural enhancement. Still, there are weaker than the normal hypo enhancement. And we should rule out pneumoperitoneum or leakage because this is a bypass operation. Thank you so much. And internal hernia, post.
I just have.
Yes.
I just have one question. So you mean that the diminished mural enhancement? What's the main reason for this?
Because what happened in any type of hernia? First of all, the venous drainage is compressed. Why? Because the vein is weak. Okay. So there are venous hypertension. The venous hypertension stop the feeding arteries. Okay, because it is one connection. So the resultant is a hypoenhancement. Is it clear for you, doctor?
Yeah, venous congestion, yes.
Yeah. After sometimes, if this hernia neglected, the venous congestion and the edema will increase up at a level that can completely compress the arteries and cause complete ischemia and necrosis and gangrene. Thank you, doctor, so much. And
Thank you, doctor.